Good afternoon, friends. This happens to be a great symposium, especially for Merrill and all of us, with the results of Landmark being presented earlier today. And the session is titled Align for the Future with a Novel Balloon-Expandable Transcatheter Heart Valve. You're joining this session to learn about the next generation, or I'd rather say novel balloon-expandable Myval Octacor transcatheter heart valve, to understand the procedural steps of planning an implant of Myval Octacor transcatheter heart valve in relationship to its multiple sizes, including the intermediate sizes and the extra large sizes, using the Octalign technique. And of course, to update ourselves about the results of Landmark trial, which were presented at the late-breaking session this morning, the pivotal randomized control trial, and of course the other evidence up to date. So I'm Ashok Seth from New Delhi, India, and Dr. Patrick Sorois, the spokesperson, as well as the co-anchor person, would be joining shortly. We have the discussants, some of the best leaders in structural heart therapies and transcatheter heart valves in the country, across the world, with Corrado Tamburino from Italy, Andres Bombach from UK, Nico Piazza from Canada, Davide Capodanno from Italy, and Nicolas van Meegen from Netherlands. And of course, we have a spectacular cast of speakers in Christian Trelexen from Denmark, Luca Testa from Italy, Tej Chet from Canada, and Ignacio Amat Santos from Spain. With these, I think I'm going to invite Christian Trelexen to give his talk on Myval Octacor, the science, technology, and his experience with the device.
Thank you. So the session is about Myval Octacor. So this is the wrong, sorry, we need to, this one. Science and technology. These are my conflict of interest. The agenda is to briefly address the Octacor design, the use of Octacor in Denmark. Then I have a case illustrating use of Octacor in complex anatomy. And then I will briefly address the compare TAVI head-to-head trial. With the Octacor, the stent frame is changed from a 3-row to a 2-row cell design, and from hexagons to octagons. The frame is 17 to 21 millimeter in height, and the lower 50% of the stent frame is covered by the skirt. The design ensures that the Octacor has the lowest foreshortening among available stent valves, around 19 to 20%, depending on valve size. Octacor is also available in 9 different dimensions, as with the Myval, the intermediate sizes and the XL sizes, 30.5 and 32. And as you can see, the use of XL varies from 6% globally up to 12% in the Netherlands. The valve is crimped directly on the balloon. There's, with the new system, a landing zone marker. And there's also a new crimper, the crocodile compass, where you can acknowledge that there are some clock device on the crimper. I know that Patrick Sorois will in detail address the use of this for commercial alignment. There's another feature that is very important, which is the Python sheet. It's the same as with the Myval, that you are actually able to take the valve out again. So whenever you have resistance crossing the native valve, you should consider taking it out again and do pre-dilatation. And it's very simple as long as you haven't inflated the valve. The only thing you have to remember is to put in the loader again, unless you want to destroy the valve. So you can see here, it's easily taken out again. This is very important to remember. This is the use of Myval in Denmark. We started early 2020 in 3 of the 4 TAVI sites in Western Denmark. We have a yearly volume of 750 TAVI cases, and until now we have done around 750 Myval implantations. Since August 22, we switched to Myval Octacor. This is the case I want to show. It's an 87-year-old male, bicuspid anatomy, also right bundle branch block and left anterior hemi block, high gradient, and also a large annulus, 705 square millimeter, a perimeter of 96. He also have challenging access because he has bifemoral grafts, as you can see here. This is the area 705, and in bicuspid anatomy, we normally aim for neutral sizing. Here we decided for 30.5 Myval Octacor, which is associated with 3% oversizing. You see the intercommissural distance, 34, which is acceptable for a 30.5 valve. There's a high takeoff of the coronaries. Here we again see the crimper, and I'll just briefly address how we use it for coronary alignment. So we don't focus on the right or the commissure. We actually just normally focus on the left main because we think that's the important vessel to protect. We then draw a line 120 degrees from the left main. The next step is then to determine the angle between this red line and the vertical line, and then we just tell the nurses to crimp the commissure 19 degrees to 12. And since every minute on the crimper is 6 degrees, it means that they should crimp one of the commissure 3 minutes to 12. Then the theory is when you advance the valve through the aortic arch, it will rotate 180 degrees, so hopefully it will end up down here. We have, of course, to await further evidence to support this, but this is the theory if you want to do left main alignment. In this patient, we dilated the grafts with an 8 mm balloon just to ensure that we could advance the XL valve. And then this is the tricusp view. Here we do pre-dilatation, as we always do in bicuspid anatomy with Octacor. And here you see the implantation where you can easily see the landing zone marker here, which the bottom of this should be at the annulus. With the XL sizes and bicuspid anatomy, the valve tends to dive. So you need to have a little pull on the system. And you can see here, nice positioning, pace on, contrast, slow inflation and adjustment. And you see the final result here. So it ends up 20/80 and absolutely no PVL. So optimal results also in bicuspid anatomy, even though Notion 2 told us otherwise. We don't, in daily clinical practice, see a lot of complications with these. So we have used it since August 22, the Octacor. We have also implemented it in our head-to-head comparison, where we randomized 1-to-1 between SAPIEN 3 Ultra and the Myval transcatheter heart valve series. This is the inclusion where in the first part we randomized between Myval and SAPIEN, and in the second part between Octacor and SAPIEN. We finalized inclusion last year. Here you see the valve sizes used in compared TAVI. So when you have the possibility to choose intermediate sizing, you do it in around 40% of cases, as you see here. In compared TAVI, we also included bicuspid anatomy in 9% of patients and valve in 4%. We also included acute cases, in-hospital cases. And here you see the overall mortality in this all-comer trial is 1.5% at 30 days and 5.3 at 1 year. These are the follow-ups, 30-day, 1 year, 3 year, 5 year, 10 year. And the MAZE is a 1-year composite endpoint, death, stroke, moderate severe PVL, moderate severe valve deterioration. We hope to be able to present this at London Valve this year, if accepted. Thank you.
Thank you very much, Kristen. That was to time and quite a vast experience of Myval. Must congratulate you. This is for the first time we see a valve, a transcatheter heart valve, which is mounted directly on a balloon, which is not sheathed at all. Look at all the self-expandable, balloon-expandable, they're all sheathed, covered. Do you think it provides advantages or disadvantages? Intuitively, you feel, will it come off this balloon as it's exposed to calcified, tortuous anatomy going through a heavily calcified valve?
I think the main benefit is, of course, that you avoid two steps, mounting it in the aorta and also taking back the pusher as we are used to with the Sapien. I think every center have probably experienced that you, in a single case, maybe have forgotten this. So we are losing these two steps, of course, and then I think it's also helping you actually taking the valve out again because you have these shoulders on the balloon. So I think this is why you can take it in and take it out of the sheet. So I think it's a good feature, and with regard to displacement on the balloon, I think the only cases where we have seen it is if you have very calcified vessels and with the XL sizes. So if you use the XL sizes, consider dilating the sheet with a 7 or 8 millimeter balloon. And if you experience what you call it resistance, when you advance the valve, you should always go down and do fluoro to check it inside the sheet and never advance it outside the sheet. If it has been displaced, then you need to take it out. I mean, among 400 implantations with Octacor, I remember one, maybe two, where we had to take it out. And this was in the beginning after we began to dilate more the sheet. I cannot remember if we've had any issues with this, even with the XL sizes. And here you had a graft, which is difficult, and even with an XL size, which is like 8 millimeter, it was possible to advance it. So just consider using a balloon to make your way.
Right. The array of sizes, again, in your experience, this is the only valve which has this huge array of sizes. We agree that we end up using that in nearly 50% of our cases, the intermediate sizing. On the other hand, do you have experience that it does benefit you in your cases? Do the cases get clinical benefits out of the intermediate sizes, or is it just easy sizing and that's about it?
I think we need to await the results of both the landmark and the compare, because you also used with the Sapien to take out a couple of milliliter or put it in, but it would be very interesting to stratify according to the annulus size, the area, and then look for the small, the intermediate, the large sizes, whether you get larger effective orifice area when you have the possibility to also choose intermediate sizing. But I think we really need to see the final results of both the landmark and the compare to actually prove this. But when we have the possibility, we choose the intermediate sizing, certainly.
Patrick, over to you.
The next one?
The next one.
Okay, that's good. Thank you.
Patrick's going to talk about the commissural alignment using the Octalign technique. And it's a very interesting and novel methodology of commissural and perhaps cornea alignment.
Okay, so I think that Chris has already done part of my job. I think the first commissural alignment impacts valve hemodynamics, access to the coronary ostia, and coronary flow following TAVI and redo TAVI. And commissural misalignment increased the leaflet shear stress, increased the leaflet thrombogenicity, and the late plaque formation, potentially leading to early valve degeneration. So the benefit of commissural alignment are ability to undertake the basilica procedure for future valve-in-valve intervention. And the Myval Octacor is the first balloon expandable with technique for commissural alignment. In a native tricuspid valve anatomy, the three commissures are roughly separate at 120 degrees with respect to each other. 180, of course, in true type 0 bicuspid anatomy. Usually the RCA originate from the mid of the right cusp, while the LCA from the mid of the left cusp. Now, the crocodile compass and the ex vivo commissure alignment is shown here. The crocodile compass is used to crimp the valve and has a calibration from 0 to 100 degrees, corresponding to 9 o'clock to 3 o'clock of a regular clock. And the Myval Octacor is placed across the crimping zone so that one of the commissure post is aligned to the 12 clock angle of the crocodile compass, while the native commissure on the multi-slide CT scan are aligned to 10, 2 o'clock, and 6 o'clock in the clock angles. Anatomical variant, where is the mid of the right coronary cusp? In this example, it is at 11 hours and 24 minutes. It's an obtuse angle of 105 degrees versus the 3 o'clock. This case has a clock angle of at 12 o'clock, so it's a right angle of 89, 90 degrees versus 3 o'clock. And the clock angle in this case is 1 o'clock, so the acute angle is 61 degrees versus 3 o'clock. Now, in the bicuspid aortic valve, in case of bicuspid aortic valve, the clock angle is derived simply from the angle formed by the horizontal line and the line connecting the right coronary artery ostium. Now, from ex vivo to in vivo, you have to understand the big U-turn. The technique relies on the fact that the valve is crimped ex vivo with one of the neocommissural posts aligned towards the mid-right coronary cusp. That cusp will automatically deploy as towards the non-coronary cusp between the neutral and the left commissure with minimal alignment. You could see here, this is outside the body. The commissure is here at 12 o'clock. At 12 o'clock, you have the right coronary artery. Now what's going to happen is that during advancement, this yellow dot is going to change its position. And these, And these yellow dots, which was there, will end up here at the commissure between the neutral and the left cusp. And the right coronary artery and the left coronary artery will be completely free. Now, the navigator delivery system has white aligners. I have to say that the aligners are for demonstration purpose. You see the white line here. That's the white aligner, placed 30 centimeters apart of the orange shaft on the same axis as the logo. The logo is at the top, upwards, and the aligner assists in maintaining the upward orientation and intuitively assists in preventing any inadvertent torquing of the system during insertion and further tracking the device across the aortic anatomy. So what is important is that the proximal handle with the logo on the delivery system and the white aligner on the orange shaft are kept facing upward during insertion within the sheath and crossing the aortic arc to maximize the change of commissural coronary alignment. So this is a multi-slide CT scan post-TAVI to look at what happens. So again, outside the body, we put the post with the commissure at 12 o'clock, and then we end up this point here at the bottom, and you can see the neo commissure of the prosthetic valve. So that's allow us to calculate the difference between the commissure of the neo prosthetic valve and the native commissural valve, and you can calculate all these angles. What is important is that if you look at the valve, you have this metallic piece here, and you can see this metallic piece. You see one of them. So what I would advise to the people is at the end of the procedure to make a filming in AP view and a lateral view, and you could do a nice reconstruction of where are the posts. So that's the final slide. This is the very first publication on the neocommissural coronary alignment with a novel balloon-expandable transcatheter aortic valve. That's the Octacor, first in man experience. And it's all colleagues of India, and one of our collaborators has put that paper together. And you could see that basically you can have between 0 and 15 degrees. You will say that you will call that commissural alignment. When you have a difference of 15 to 30, you will say mild commissural misalignment. 30 to 45 is moderate coronary commissural alignment, and finally 41-60 severe commissural misalignment. And in that very first series, where there was some learning aspect, of course, there were 22 consecutive patients with post-TAVI CT, and the coronary flow was preserved in all cases, no procedural-related complication. And altogether, we had 69 perfect commissural alignment of mild misalignment, and these number 4 and 6 with moderate and severe. We have in the paper, we described the bicuspid and the tricuspid because it was almost 50-50. So in conclusion, there are a few techniques described for commissural alignment with self-expanding, evolute, accurate neo2, portico, navitor. No technique for balloon-expandable valve, at least to my knowledge. It's easy to practice. It's a dedicated delivery system. There is no special hardware or software necessary. No need to torque or rotate the delivery system, reducing the risk of embolic events, vascular complication, and damage to the delivery system. However, there are limitations, of course, very tortuous anatomies where the center line of the aorta is tortuous, forward, backward, as well as spatial orientation of the aortic annular plane may affect the ability of the simplified model to reflect the real trajectory of delivery catheter from the femoral artery to the aortic annulus. That's it, Ashok.
Thank you very much, Patrick. Comprehensive. May I just request you all to be interactive? Please come forward and ask questions. There are mics around, and so feel free to clarify any thoughts that may be coming by. Nico, could I just ask you around how important do you think commissural alignment is in a lifetime management? Are we just getting onto a fad, or do you really believe that that's how all valves should be, and should we get more robust at it? This is a novel technique, as you saw.
Right. Yeah, no, definitely. Commissural alignment is something that every valve needs nowadays. I think in the past it's something that we overlooked, but it's something that, from hemodynamics to coronary access, as you mentioned, Professor, I think this is something that's important.
And Luca, I know you're going to present this on the board and explain a bit more about as we get on with the case. Because I think you've described it in the case. So
Sure.
In the interest of time, we will move on to the case. Nicholas, are you here? Because Nicholas was supposed to be us. Oh, there you are. Right at the end.
It's not an hologram, it's a real guy.
You never know. Okay, so I'm going to exit this and go with the case. So this is a patient with a severe aortic stenosis, and it is This patient is from thorax, operated by Nicholas himself at the Thorax Center in Rotterdam, 84-year-old male, no relevant past history. He presented with heart failure resulted from a rapid atrial fibrillation and had a diagnosis of severe aortic valve stenosis. Good LV function, ejection fraction was 50%. He has critical aortic stenosis combined with mild to moderate aortic regurgitation. There is mitral regurgitation, moderate, as we commonly see in many of our severe aortic stenosis patients. Here's mild coronary artery disease, mild to moderate coronary artery disease, no critical stenosis. And this is his CT analysis. He's got a tricuspid valve, heavily calcified, Agatston score of close to 8,000. His annular dimensions, area of 537 square millimeters, area derived diameter of 26.2 and a perimeter of 83 millimeters. He's got adequate size access vessels, as you can see. At his heart team meeting, Nicholas and his cardiac surgeons decided that this was a symptomatic severe aortic stenosis with an increased operating risk due to age. He had suitable access for a transfemoral TAVI, and therefore the consensus was for TAVI to the femoral access. It was decided to put a 26 millimeter Octacor, and we'll actually now go on to the video of the case which Nicholas performed a few days ago. No, what we're going to do is, because CT has been discussed during the case, and it's more to do with Octalign, Luca, during the case, we'll stop the case, and Luca is then going to draw the Octalign as it was done, expanding on what Patrick has already emphasized. We play the...
Click it.
Yeah.
And click once more. There you go. And once more, and then it starts. That's only nurses.
Of an established valve platform. I'll do the case together with a nursing team that includes Louise and also Stefan. Stefan is our dedicated PA for the structural valve program. And then we have, from the technical point of view, we have Jojo, we have Martin, and we have Titi. And then obviously there's also Lynn from the nursing support who will take care of the patient. We'll do the procedure under local anesthesia. So that is why we really have to interact with the patient to make sure that the patient understands what is going to happen during the procedure. We also have the pleasure to host one of our good friends, Professor Luca Testa from San Donato in Milano. He is also here to support us with the imaging. And then from Merrill, we have Puneet Gupta, and we have also Majuresh to support us with the procedure. Luca, why don't you explain to us this concept of coronary and commissural alignment and help us how to determine that by CT?
Well, sure. Thank you for the introduction, Nicholas. And as always, a great pleasure to share some time with you in this fantastic place. So let me say that as soon as the Octacor technology has been introduced, the concept of Octalign has been introduced as well. What we are talking about is just a way to achieve a perfect coronary or commissural alignment after the procedure. So let's start from one little basic concept. The two coronary ostia are basically placed at 120 degrees from each other. As you can see here, the very first thing I'm gonna do is to try to understand the position of the right coronary. So in a short axis, the aortic valve, you see that the right coronary is just at 12 o'clock, while the left main of the is just at 4, 5 o'clock. So in other words, what we need to understand is where the crimper has to place one of the commissure while crimping on the crocodile the valve. So I know that it sounds counterintuitive. However, during the navigation into the aortic arch, this commissure in front of the right coronary will basically turn 180 degrees just to stay perfectly aligned during the deployment. So in other words, the crimper will just place one commissure in front of the RCA because this point will turn automatically 180 degrees to achieve perfect coronary alignment.
Luca, if we compare the commissural alignment with the coronary alignment in this particular case, are they more or less the same?
I have to say we are lucky, Nicholas, because the commissure, well, the midpoint of the commissure is exactly correspondent to the coronary ostium. So, in other words, this is not the case every time, but let's say that in the majority of the patient, and I'm talking obviously about tricuspid anatomy, because if it's bicuspid or any other configuration, this is not true. But there is also the possibility to align with the center of the commissure. Again, in this case, either you scroll up or down, you see that at 12 o'clock, you are right in the middle of the cusp. So, this case, we are both doing commissure and coronary alignment. So, I would say we're lucky, but it's a good way to show the possibility. Let me just show you one little thing again. The commissures in a tricuspid configuration are placed from each other at 120 degrees, as you can see here. You can even measure these angles if you want, but nevertheless, what makes the difference at the end is that you can use this technology and have a perfect coronary or commissural alignment. In this case, both.
Yeah, that's very clear. So most of us are familiar, obviously, with commissural alignment using these self-expanding valve frames, but now we also have the ability to do commissural alignment or coronary alignment with a balloon-expandable valve. And this is also going to be demonstrated in a second. So let's briefly go here to the swimming pool here, where we have this Myval Octacor. And if we can zoom in on the valve, you will appreciate that the valve is different from others in the way that it has 2 layers of struts. And this is unique. Most others have 4 to up to 9 strut layers. And the struts themselves, they have an octagonal configuration. So you see the 2 layers, one here, with also the sealing fabric around it. And now what we want to do is we want to identify the commissures. You see 1, 2, 3, and we will use one commissure to point at 12 o'clock. And to do that, the crimper, which is called the crocodile compass, has the numbers of the clock. And can we briefly show that also on camera? So you have here from 9 o'clock to 3 o'clock, and we know by the evaluation by Luca that we need to be with one of the commissures at 12 o'clock, because that is where the right coronary was. So if we will crimp it at like this at 12 o'clock, just a second, then if we bring the delivery catheter as such in the patient, it will go from posterior to anterior, from the descending to the ascending aorta, and by doing so, the rotation will change by 180 degrees and you will have commissural alignment. All right, Majuresh?
So Luca had his 4 minutes in the video.
Yeah.
But Luca, you still have your 2 minutes around this commissural and coronary alignment. You mentioned a lot of things there. Could you help us understand that?
Yeah. So let me just soften the message, because I don't want to deliver the message that this is true for 100% of the cases, because as you've seen before, according to the CT scan done after the procedure, you have, well, let's say almost 70% of the cases where the alignment is really, really good. However, we need to consider tortuosities, we need to consider the anatomy of the aortic root, we need to consider that some cases our patients may have this huge aortic arch. So we say that, at least in theory, it should be 180 degrees and you have this post and the opposite at 6 o'clock. However, we have seen it is not always the case. However, we need also to remember the problem of the commissural alignment or coronary alignment is mostly related to self-expanding prosthesis platforms. So it's absolutely right that we keep going in this direction. It's absolutely right, and I do agree that we need to learn how to place these valves. However, we need also to remember that it's specific in the world of balloon-expandable valves. This is absolutely important for the second procedure, which will be the next disease we will be facing in the upcoming years. So let me just say that what we have seen in that case with Nicholas was honestly really educational, I have to say, because everything was there, and the commissural and coronary alignment was just perfect. And also, you'll see the end result. But however, I don't want to spoil it. What I want to say is, for bicuspid, it's really different, because what I typically do is I align with the left main, because typically is what you want to see. However, the rotation is really not predictable that much. And this is a thing I want to say, because instead of saying, look, this is 100% of the cases, which is not real, we can say that, okay, this is real, but there are cases where it's not perfect.
So it's a good approximation, but maybe for the audience, what to do when the commissural alignment and the coronary alignment are not the same. So in this particular case, it's almost exactly the same, but sometimes the coronaries are a little bit off axis. So what do you want to do then? Do you want to achieve coronary alignment or commissural alignment? For Octacor, because it has the shortest stent frame on the market, you don't mind about coronary alignment. You want commissural alignment because that will maximally determine your hemodynamic performance of your valve. But if you have a long stent frame that might end up in front of the coronaries, you might want to prefer coronary alignment because, as Luca's mentioning, you want to find the best proper way to re-access the coronary. So that's why you would go for coronary alignment with large stent frames.
Yeah. Also, if I can just add one more comment, this is really, really important, especially in consideration of a future event of degeneration. And obviously, it is even more important if you have a small anatomy where everything is just a problem. If it's a big anatomy, it's less of a problem. However, it's absolutely important that we keep working in this direction. And I have to say, please, to all the interventionalists, get familiar with the CT scan analysis, because this is crucial.
Luca, can I just ask a quick question
Please.
about what's the influence of the on-fast viewing angle? Because every patient has a different on-fast viewing angle. One's going to be RAO 50, cranial 20. Another one's going to be RAO 67, cranial 87. But then that is at a certain angle, but then you're using this concept to measure, the clock. How does that influence your appreciation of,
let's say that
commissural alignment?
The aortic root is always rotating in a different way as compared to the ventricle, and this is because of the embryology. So if these two angles of rotations are quite similar, this rule will be absolutely the case, as we have shown in the Nicolas case. But honestly, especially when you have, let's say, an horizontal aorta, this rule may not apply. Let's just say also that in the CT scan analysis that have been done, there were some cases with bicuspid configuration. And so, again, we need to refine this technique.
But I think you hit the nail on the coffin when you said for horizontal aortas, or for vertical annulus, yeah, it's the same thing. Then it might work less. It works probably better when your aortic root is vertical and your annulus is horizontal.
Surely, when it's really a U-turn, it works a lot. When it's not, because maybe it's a V or it's really horizontal, we don't have enough data to say that. But definitely, if it's a normal, let's say, configuration of the leaflet, is a relatively, let's say, horizontal aorta, completely different words. Definitely.
All very relevant points, and I think we've got to really work more at it in terms of lifetime management of a patient, getting increasingly important to devise new methodologies and
Go ahead
understand
and
these
crimp
methodologies.
this.
Let's get on with the case, because Nicholas is getting impatient. He's waiting there.
So we started with a right radial access. So that will accommodate the sentinel filter in a second. And then we have a double access on the right side in the groin. We have a 6 French sheath in the superficial femoral artery, and we have an 8 French sheath that is leaking around in the CFA, in the common femoral artery.
This I think is real time,
Now.
Nicholas. Correct?
One filter.
Took you
It is. I can confirm
30,
it is.
45 seconds.
Open the handle. Now we can make a bend on the distal end of the catheter. We
It's still our
rotate,
default to
we
do
rotate,
filters in all our patients.
Pull up.
Yeah.
and then see whether we can probe. Ah, that's it. All right. Nice. Voila.
And we'll have a surprise at the end of the procedure.
Can you please replay the aortogram? Wow, that's a lot of calcium. See a real chunk of calcium extending from the annulus into the ascending aorta. There is also some protrusion of calcium in the LVOT, and that is important to take into consideration. Obviously, we are at risk for aortic root rupture. And the good thing with the Myval Octacor is that there is an extended sizing matrix. So you can basically tailor the size to the anatomy and to the dimensions of the patient without having to change too much with filling pressure. So we know that with a Myval Octacor 26, we will have 1% undersizing, and I think that is to be on the safe side. So if you do a nominal deployment of the Myval Octacor 26, we will have 1% undersizing, but also obviously we hope to decrease the risk for perforations. Okay, so let's flush these catheters. Okay, this is our baseline situation. So critical aortic stenosis, as we already learned from the echo. So LV pressures up to 255, aortic pressures 124. Clear, no discussion here. So let's bring on the stiff wire, the Safari extra small in this case. And then we're gonna exchange our 8 French sheath for the Python sheet. We walk this out, and then I will briefly use a pigtail to get a more favorable positioning of the Safari wire. You know, it's the eye for those details that help you minimize the risk of LV perforations as well. I think we are in a waltz with the papillary muscles. Yeah, that's better. Okay, for this anatomy, we'll also prefer to pre-dilate the valve with a 24mm balloon. So that's somewhat undersized relative to the annular dimensions. Obviously, again, to minimize the risks for aortic root perforations. Okay, so this is the Python sheet that goes in. Now we should control all bleeding here, and that is the case. So let's dilate the Python now with the dilator. So Stefan will exchange. What's the size of the dilator, Stefan?
Yeah, it's an 18 French dilator.
Yeah,
Just
okay.
for the valve.
Yeah. So it will pave the way for the Myval Octacor. Here we go. So our patient is wide awake. Lynn is interacting with the patient. She explains what we're doing. So now she already informed the patient. Well, we need more wire. There you go. She informed the patient that we are manipulating in the groin. There can be some discomfort, but most of the time it is manageable. Okay, so take out the introducer or the dilator. So we paste on the wire. No temporary pacemakers, there's no venous access here. And we have one crocodile on the LV wire. The other crocodile is in the groin, right at the incision piece. So there is no needle involved, just connected to the skin. Okay, do we have sensing? We check the sensing with Tommy.
Yes, there is sensing.
We have sensing. Is Stefan ready?
Yes, ready.
Stefan's ready, so we go and pace 180 beats per minute. Start pacing.
Start pacing 180.
There's good depression. Go. And down. And stop pacing. Store. Okay, so this is good preparation. Nice pre-dill. Yeah, we have normal conduction, so we can disconnect the crocodile and we can take out the balloon. The frame is nicely in between the two dots of the balloon, so we are happy with the crimping. And now let's continue navigating through the thoracic aorta, so I can flex the catheter like we used to do with balloon expandable systems. That's going very well. Let's unflex, store, compressed on the balloon, so no additional maneuvers here in the patient. Can we fill the pigtail catheter? Okay, so this is a little bit too high, too low, sorry. So we're gonna bring up the Octacor. And so we have two markers. You have a central marker right in the middle. That is the middle of the frame. And then you have the two big markers on both ends of the frame. That is, those are the stoppers basically of the balloon. And then you have that other marker. Can we briefly show that with the arrow? That is at up to 3 millimeters from the distal edge of the frame. Can we? Yeah, the big one. Go down a little bit, that's it. So that one we want to land on the annulus, and that will give us an overall depth of a maximum 3 millimeters. So this is a very reliable way of positioning, provided that you don't have foreshortening from the LV. Well, and this is exactly what you get with these octagonal struts, these two layers. In principle, it should stay where it is now. Start pacing.
Start pacing on the top.
Okay, go 2/3. Contrast. Hit it. 21, 22, 23, 24, and down. Stop the pacing.
Stop the pacing.
Okay, forget about the gradient, that has been resolved. We do see a very low pressure in the LV. Diastolic pressure is very low, it dropped from 7, more or less the same. And then the diastolic pressure is somewhat low, it's 40, but this can reflect the stiffness of the aortic vasculature of the aorta. Yeah. That's okay. So now, let's make one more in an RAO caudal projection that also would allow you to do video densitometry more properly. So you want to get rid of the aortic, of the aorta, of the descending aorta. Let's just see if we can get rid of the parallax also. Yeah. As good as it gets. Ready?
Ready.
Nada. Perfect. Okay. So that's good. We are happy with this. So let's review the aortograms, both aortograms. So this is a cusp overlap view, so an RAO caudal. And what you can see is that there are two commissures on the right-hand side of the screen. And this is exactly where the right and left coronary cusps are overlapped. We are isolating the non-coronary cusp on the left side. But now we clearly can appreciate the two commissures on the right side of the screen. Can we briefly show that with the arrows? So the two commissures, higher up, those two. Yeah. That's that. And now sand them in. So let's go to the coplanar view. And there you want to see the 3 commissures. So you want to see one commissure in the middle and the 2 others on both ends of the aorta. So there is one, the middle one, and then the 3rd one. Nicely commissurally aligned. Take out the filters and then let's see whether we caught some debris here. There you go. So this is 1, this is 2, and now, voila, filters are out. Okay, here is this yellow piece of calcium that is caught. It's macroscopically visible, so this is 2 or 3 millimeters in size, so this is quite significant. So this wraps up the recorded live case. I think I'm very pleased with what we were able to demonstrate. We demonstrated the use of commissural and coronary alignment. We also illustrated this new Myval iteration, the Myval Octacor, and also the options that you have in heavily calcified aortic roots and how to approach this in a safe and controlled way. I think the end result is perfect. No AR, no residual gradient, and also a patent hemostasis. And then on top of it all, we also captured some debris in the filters. So I think a successful case. Thank you very much to the entire team. Thank you for all the support, and thank you for watching. Bye-bye.
Thank you very much, Nicholas, and thank you to your team.
Yes.
That was a great case. Heavy calcification, severely calcified valve. You got it right. The sizing. I mean, you were slightly careful in your sizing, rightly so.
Yeah.
I mean, that was when you blew up that valve with a balloon. I could see all your muscles forcing the valve open.
That was not on camera, luckily. but I think it really illustrates. And in the beginning, I was a little bit skeptical of the intermediate sizes, right? Is it so important? Because you modify a little bit the volume in the balloon of your to deploy the frame, and then it will be okay. But in these kind of hostile anatomies, I think you don't want just a patient-tailored valve selection. You also want to have a anatomy size-tailored approach. And this is what the Octacor allows you to do.
That was a conservative approach, but at the end we saw in the aortogram it fitted well. If there's heavy calcium, you can get to that 0%, 0% oversize, get to -1 as you did, and still fit the valve in. Patrick, are there any questions? And I'd like you to comment.
There is only one question, anonymous, 26 minutes ago, so maybe we have given the answer in the meantime. Is it possible to implant the Myvalve according to coronary alignment instead of commissural? And I think in my presentation I show an example of bicuspid where you just go on the right coronary artery, that's it. With all the comment on the plane of the things, that's make the things difficult. And I think that Luca has also emphasized the point. Says, yes, you can do it. That's the answer, yes. Anything else? Please use your system. I have here in front of, go to the microphone. There are numbers there, 2, 5, 6,
Can I make a comment?
3. Yeah.
Please, Corrado, this is an open house.
Very interesting case, in my opinion, for several reasons. Let's see 2 or 3 of them. So first, in this case, we don't care. It was a case that play of chance has both commissural and coronary alignments. But in this case, was important the commissural alignment. Even though the patient was 84, so we don't expect a long life expectancy in this case, but this is a good example for younger patient. Second point is that with this valve, in this case, an all-expandable valve, balloon-expandable valve, we don't care coronaries because we can cannulate the coronary at any time due to the shortness of the frame. The calcium was a little bit, potentially dangerous for the rupture. So you choose a -3% of the sides of the annular sides. This is a wise choice because you didn't overstretch the annulus. But in this case, I ask a question considering this specific patient and not the valve that was excellent. In this case, for 10 years younger was the best possible valve. Would you accept a certain degree of aortic insufficiency by a self-expanding valve with a lower risk of annular rupture? So I would say no.
Well, I try to avoid aortic regurgitation at all costs. Don't forget, this was a hypertrophic ventricle that has not been exposed to any kind of aortic regurgitation up front. So those ventricles don't do very well if they all of a sudden get exposed to aortic regurgitation. And this patient really was admitted with decompensated critical aortic stenosis. So I definitely would want to go for an option to avoid aortic regurgitation. Again, if you would have an other balloon expandable valve, you would have chosen a 26 millimeter and added -3 cc's of volume in the balloon, but then you are making you are approximating the sizing. Here you are much more accurate in terms of sizing.
This is another important point, that you avoid the distortion of the frame, and so the alignment of the commissure is perfect in the new valve. And so the durability is supposed to be longer.
And to add to the first comment on the alignment, so these are the lessons learned in the last couple of 2-3 years maybe, that we should aim for commissural alignment in all our patients. Nicolo also addressed this. And for the first time, I've seen a technique that allows me to do commissural alignment with a balloon expandable valve.
Yeah.
This is novel. This is a novelty. And this is very important. And you know, I can tell you a secret. You can use this technique also with other balloon expandable valves, because the theory stands. It also will work in other balloon expandable valves.
Yeah, and one thing, if I can add on this, I mean, it is so easy that it doesn't make any difference in terms of the technicalities that you apply during the procedure. So it's still the same procedures as you do, but the crimping is done outside the patient. It's done by the technician, by the nurse or whoever it is. And it's really an add-on in terms of what you can really deliver for your patients without, you know, increasing the risk on nothing, and that's really important.
And that's basically what you did, because this was not our usual approach with balloon expandable valves.
Yeah.
You informed, instructed our team, so now our nursing staff is crimping accordingly.
Yeah. And for me, it was very relaxing because it was just outside the door. So it was.
So are there questions there, Patrick?
Yeah, I think that it's a little bit the same question coming back, but that really showed the interest. Do we have a confirmed range of tortuosity significance of horizontal anatomy where we have full confidence in coronary commissure alignment? And I think that on one hand, Nicolo has responded that. Maybe you can elaborate a little bit. Repetition is the mother of education, okay? And on your side also, you can maybe elaborate a little bit of try to make very concrete that point. I mean, because basically you are thinking about assessment of the plane of the valve, tortuosity, that's another story, but...
I would say the easiest way to think about it is that you're crimping the valve, as Nicholas showed. Is this empty? Hold on. So you're crimping the valve this way, right, on the table, and you're using a clock. And now, let's put it this way. So I'm on the table, I'm crimping. Imagine the patient lying down on the table now. And so their head is here, and their feet is here. And so it would work best, I would think, if the valve would be sitting this way in the body, which means it's horizontal in the body. I think there might be a way, there must be a way. It's all geometry, it's all mathematics. There's a way to understand for sure if the valve is off plane
Because
what a clock you need
the
to...
question is more subtle than we think. They say the range.
Right.
Okay, what threshold of plane, out of plane, will be prohibitive?
I don't know. I don't have much experience with this technique, so Luca,
No
maybe...
one has, I have
yeah.
to say, and this is one of those impossible questions for the moment, because obviously there must be a way, especially, by using artificial intelligence, like say, for example, extrapolating the final position by the CT scan analysis. But at the moment, I have to say that I don't know. And, well, one thing it has to be said is, obviously, there's no way to understand while the valve is crimped, what is the position of the commissures. I mean, you cannot check. I mean, let's say that the human beings commit errors. Okay, let's say that you want to check. It's not possible because you are in the body. The only thing that you can check is the symmetry of the stent within the two markers, as Nicholas showed before. That's the only way you can check. So.
Well, there might be a solution. I think you mentioned the en face view. I think we always need to, our working point should be, our starting point should be the coplanar view for this technique. Yeah. And I think in future iterations, it might help to have 3 additional dots markers to identify the commissures in the crimped position.
Yeah. Or maybe just one.
And this is what let's call it.
Let's get you guys into the lab again. I'm sure next year we'll have this session on again.
Yes.
I was going to ask Davide. Elegant valve. I mean, it's almost like a stent, isn't it? Like we used to implanting a coronary stent. Comes in, you do nothing with it, you just push it across. No manipulations, nothing pulling, nothing turning, and you're there, and you boom. I mean, I don't want to be biased, quote unquote. No conflict of interest apart from the fact that I'm from India. But yes, what did you think of it?
I can give you my reaction. So now that we are entering into the TAVI versus TAVI story, obviously, because of course the story with Saber is continuing in the long term, but we are reassured. We will see more and more studies of TAVI A versus TAVI B, and we can expect a lot of non-inferiority trials. So we need to look for differentiating characteristics. And when a new valve has something which technically improves and simplify the procedure, this is the right direction. And I think it stimulates the competition among the various manufacturers to improve. So I can only think well of seeing something new introduced in the market.
So one thing for the audience maybe that we should make clear, because initially the first time I heard about the intermediate, I was, hey, prove me that it improved. I think there is 3 things that has to be said. Number 1, it's a 9 tube of metal with laser cutter of different dimension. Okay, it's not like in stent, a big balloon in the same platform. The second point is that you can still modulate the intermediate. That's a question to add 1 ml, 2 ml, so that's compatible. And what we have presented in the previous session on the technology is the fitting index. Axel Link came with the fitting index, and the fitting index is basically the nominal diameter divided by the diameter derived from the multi-slice CT scan area of diameter. And what is interesting is that when you are in the correct fitting, okay, then you eliminate somewhat the pacemaker intervention of the difference. When a Myval, when a Sapien of eventually an Evolut is clearly outside the fitting, so there is a misevaluation by the clinician, then you start to see problem. So the fitting is something which is more precise, more appropriate, and maybe at some point will deliver some clinical benefit, but it will take time to prove the point. Yeah.
Andreas, you've been the principal investigator for the landmark, and it's going to be, talked about soon.
Will be presented.
But your experiences around the device. Not the study, the device.
I think very quick. It's an everyday device. We've started using it. It's it's slick, and I can tell you that once you have intermediate sizes available, you will use them in probably half the patients. And to add on, just, you know, the concept of oversize, of making something a bit bigger, less round by adding 2 or 3 milliliters to like we used to with the existing systems. For the life of me, I cannot think that that is a good thing, because, you know, these valves are created to be round at a certain diameter. And again, what Professor Royce said, it's not valves crimped on different balloon sizes. These valves are made to be round at a certain diameter, and I can't think that these delicate devices that have to last 10 years would work equally well when they're expanded outside this range or under-deflated. So I think, you know, being as precise as possible, I'm sure will translate into long-term benefits.
Thank you. A bespoke suit is what it is.
I mean, that's pretty good. I mean, Anonymous, 11 minutes ago. What range of undersizing is safe for heavy calcified annulus without risk of valve migration? Who wants to take that one?
Yeah, so I think you should, Nicholas, because you're the one who did that undersizing with the thought process behind it. So you could take that up.
I find it difficult to come up with a number.
Yeah.
I would, and it also depends on the degree of calcifications, right? So it is an interaction of sizing in combination with the amount of calcium. Obviously, if you have an Agatston score of 8,000, there is more leeway, and you can more liberally undersize as compared to an Agatston score of 3,000 in the same dimension.
Yeah, you know, I think that, you know, points to the idea of supraannular sizing. And I remember cases that John Webb presented.
In the bicuspids, right?
Yeah, also with bicuspids or even, you know, tri-leaflet valves. I remember cases that John Webb presented many years ago. You know, he used to say -5% oversizing, 0% oversizing, and he had good anchor and good and no leak. The idea is that you almost have about 2.5 times oversizing happening in the supraannular area. That's where the anchoring and sealing happens, not at the annulus. And so, you know, I think in general, we perhaps oversize too much with some valves, and I think we have to give credit to the Myval system that, you know, now they have this amazing array of valve sizes. Imagine since the beginning of time, it's been 20 to 23, 23 to 26, 26 for every valve. But they're all different. So I think we have to give them credit for coming up with this novel sizing scheme.
Can I just have an additional comment on the sizing issue? And that's the comment around this is the two, undersizing is not the real term. What we're talking about is optimal sizing, and optimal sizing for a heavily calcified valve or a bicuspid valve is slightly different to a tricuspid valve. This is supraannular fixation of the valve, and therefore we tend to, in bicuspids, we in severely calcified valves, because 30% of the TAVIs we do are bicuspid, and we therefore tend to anchor it. We dilate it less so that we can anchor it better. We don't over-dilate, pre-dilate it, but we anchor the valve better in an anatomy which is heavily calcified or supraannular calcification due to bicuspid.
So in this question, I think the most annoying situation will be an embolization of migration in the left ventricle. And the most beautiful case that I have seen many years ago is an operator who used an in-way balloon, go through the valve, inflate the distal part first, pull back in the aorta, and then inflate the second part of the inner way. That was amazing and beautiful result for something who looked catastrophic, you know, to have an Edwards in the middle of the ventricle, fortunately still on the guide wire. That case report has never been put in the literature. It was brilliant, because when you have one time the situation, you know what to do, yeah?
Right. I think we should move on in the interest of time. I'm looking at the clock there, but perhaps at the end we may have time for some discussion we do need to go on to the next talk, and that's the TAVR in extra large annuli using the 32 millimeter Myval Octacor. Stage sheet is right here for that.
This one?
Yeah.
Microphone, okay.
Thank you. Thank you very much. It's really a pleasure to share with you our early experience. I'm from a country where MyValve is not on the shelf, and we have to really think carefully about the rationale for use of the device, and I'll take you through that with the case I'm going to share with you. So this case is a 75-year-old patient with hypertension, diabetes. He's tall and overweight. His BSA is 2.4. He presents with progressive dyspnea. He's got no significant coronary disease on his invasive angiogram. His STS scores calculates at 1.1. He was reviewed by our heart team, as all of our patients are. Given the absence of surgical indication, we felt he'd be well served with TAVR. The patient strongly preferred a TAVR option, and then we looked at a CT scan, which showed an annular area of 750, perimeter of over 96. And then when we measured the LVOT area was 761 at 3 millimeters below the annular plane. He had a tricuspid valve with an aortic valve calcium score of 5,327 Agustin units. His femoral access looked good. There was some calcification at the common iliac bilaterally, but nothing significant, and well suited for any transfemoral valve delivery system. So we sort of considered as a team, what are our treatment options? If we look at what we have existing available to us, the SAPIEN 329 and the Evolut R34, there is reported experience of use of these devices in extra large annuli. In this your paper describing a European experience, extra large annuli was defined as an annular area over 683 millimeters squared or a perimeter more than 94. And you can see the results are pretty good. The device success is high. There is a frequent need for post-dilatation, and in the case of the balloon-expandable, many patients receive extra volume during the valve deployment. And certainly in our practice, we do about 400 TAVR a year. We've done lots of patients with this sort of a strategy. But in this particular patient, the annulus area was really at the upper range of what had been done with this kind of volume modulation. You can see in this series, the median area treated was 710, and our patient was 750. An additional consideration that we thought about was the relationship between the annulus and the LVOT. We know from this paper, looking at the use of balloon-expandable SAPIEN valves in the treatment of large annuli, that there's an important relationship in the risk of PVL when the LVOT and annular dimensions differ. On the right, you can see a cartoon illustrating the scenario when the LVOT area is larger than the annular area, as was the case in our patient. And there, the risk is that the PVL is increased because the ceiling zone really is now limited to the annular level. And that is a less favorable situation than when the LVOT tapers, when there's less risk of PVL. The other thing notable in this series, and it was referred to already by the panel, that when we take valves that were designed for a certain size and stretch them beyond their engineered size, there is a risk of central insufficiency, presumably from stretch of the stent, as well as the then resulting malcoaptation of the leaflets, and that was seen in a small minority of patients in that series. So the Myval Octacor is available in two large sizes, the 30.5 and 32 with an area of 804, which we thought would be the right valve for this patient. We sought and obtained Health Canada special access to implant the device. We calculated that we would have 7.2% oversizing at the annular level and 5.7% oversizing at the LVOT level, and there was no calcification in either of those locations, making this quite a safe strategy to use. We did a percutaneous right transfemoral approach, which conscious sedation. A Lunderquist wire was used to deliver the valve, and we pre-dilated with a 25 millimeter balloon. I must say one of the learnings for us was the extra time required to deliver all of the contrast. This is a lot of contrast that's needed in these large diameter stents. And so we used a two-stage inflation and a long, careful pacing run to ensure we got all the volume in for the valve deployment. And you can see in the final aortic root angiogram there, the echo the next day showed trace PVL, a very good gradient and an excellent DVI. So as is the case for many of our patients, we brought him back just for clinical surveillance and a follow-up CT scan. So you may be interested to see the post-CT dimensions in this patient, which showed an inflow area of 764, exactly matching the LVOT dimension on the pre-CT. The mid-frame was 769, and the outflow flared a little bit at 865. There was no halt. Equally, and we've had a lot of conversations already on the panel today about commissural alignment. So this was the pre-procedure commissural alignment planning with an 85-degree angle, and the valve was crimped accordingly. And here you see the post-CT. So on the left is the pre-commissural location. On the bottom, you see the post-CT analysis demonstrating that the neocommissures are nearly perfectly aligned with the pre-CT. And on the right, you can assess the coronary alignment. The coronary is around 4:30 there on the clock, and the leaflet is exactly opposite. So a nice case illustrating success of a commissural alignment strategy during deployment. So this case, I think, echoes what's already in the literature. This was a case series of 10 patients who underwent Myval Octacor 32 at multiple European and Asian sites, an average annular diameter of 765, procedural success obtained in all cases. And I found interesting in this paper that they reported the experience of one of the sites highlighting anatomic contraindications to TAVR. And out of the 2,200 patients screened, the most common reason not to be able to do a TAVR was that the annulus was too big. And the availability of the Myval 32 certainly helped to address that in many of the patients. And we've recently had reported in the literature an implant of the Myval 35, which treated an annular area in that case of 883. So the options continue to expand. And finally, the landmark data that was presented earlier today was on the randomized trial. As mentioned by Professor Saraus, there's an ongoing nested registry of large annulus. I understand the sample size target is actually larger than 100, but quite a few patients have been enrolled, and so more data is coming. Thank you very much.
Very good.
Thank you. Thank you, Tej. That was a comprehensive presentation. In the interest of time, I think that your last slide was most appropriate, that we need to address the landmark pivotal randomized controlled trial. This was presented this morning, and I think it just needs to be presented and analyzed again with you all here. So over to Ignacio.
Thank you so
much. Please go ahead.
Thank you so much, Ashok. So for me, it's a great honor to present the landmark randomized trial. As you know, Professor Serruit presented this morning. Many of you might have been there, so now you will listen to the version in Spanish accent. And those who were not in the meeting this morning, I'm very honored to present you for the first time the results of the landmark trial. These are the disclosures. So the major evidence of TAVI has been mainly obtained from the SAPIEN and the self-expandable Evolut THV series. This is the contemporary standard. And this trial is really relevant because it's comparing a new THV device, the Myval THV, with those contemporary series. These are the countries that participated in the study with some of the investigators. It's important to highlight the Clinical Event Committee with José Luis Pomar, the core lab of Horeco, Angio, and CT, the ECG core lab with Marie-Claude Maurice, and the close monitoring board that you can see in the slide. Apart from myself, I want to highlight the principal investigators that were the top enrollers that you can see in the slide, but also those investigators, co-investigators, study nurses that did a great job, hundreds of people in the world doing this, who will keep doing this for 10 years, because this will have a 10-year follow-up. This is the design of the study. As you can see, the randomization was performed between Myval THV series and the contemporary series that were equally distributed in this cohort. And the primary composite endpoint was the VARC3 criteria to 30-day follow-up. But as I said, we will continue this for 10 years. Is to highlight also that all these criteria were VARC3 based, and this is one of the first trials based on this new evaluation. So these were the sizes included in the trial. The extra large, as we already mentioned, were not included, and also, although it was included in the design, no cases were performed with the Evolut THV of 23 millimeters of diameter. This is what was presented before regarding the intermediate sizes used. In landmark, intermediate sizes were used in almost half of the patients. There has been some studies published before, retrospective studies, that also presented rates of intermediate sizes above 40%. I want to highlight the Myval study for two reasons. First, this was the first study comparing the two balloon-expandable devices published in Heart in 2022. Second reason is because I was the senior author, so this is a good reason also to highlight the study. And what we found in that study is that the hemodynamics with Myval was better. It was retrospective, but the size of the annulus, the calcification, the eccentricity, this was matched between the two cords. And this was a hint of what we could find and what I will describe later. The hypothesis of the landmark trial was that the Myval THV series was non-inferior to the contemporary THVs. The assumed rate of events was 26.1% for each group, which was aligned with other similar trials. The non-inferiority margin was 10.4, one side alpha 5%, power 93%, which is also similar to other trials comparing head-to-head devices. And the sample size, 768 patients. What was included in the primary endpoint was all-cause mortality, all stroke, bleedings, acute kidney injury, major vascular complications, the rate of moderate or severe prosthetic valve regurgitation, and conduction system disturbances. Regarding the baseline characteristics, I just want to highlight the similar distribution of the gender, age, the symptoms, and also I want to highlight that about 3/4 of the patients had low risk according to the STS score. These are the baseline characteristics. I'm not going to stop just to highlight that they were evenly distributed amongst the two cohorts. And these are the echo parameters equally distributed in a similar way in both cohorts. And I want you to realize that about 6 and 7.5% of the patients in both cohorts were bicuspid. And this is different from prior trials where bicuspid aortic stenosis was an exclusion criteria. This is the main result of the trial. The trial presented a rate of the primary endpoint of 24.7% in the Myval THV series versus 27% in the contemporary cohort, meeting the non-inferiority with a p-value of 0.0001. This means that the Myval had an absolute risk of -2.3% related to the risk in the contemporary THV cohort. And the upper one side confidence interval went up to 3.8%, which is far below the non-inferiority margin that, as I mentioned before, was settled at 10.4%. We already discussed the primary endpoint, but what happened with the secondary endpoint analysis? If we go one by one in the items, mortality and stroke were really similar. The rates of bleeding and kidney injury were numerically higher in the Myval THV series, but this was not statistically significant. And the opposite happened with moderate or severe leak, new pacemaker, or major vascular complication, which were numerically lower in the Myval THV series. If we cross the sizes of the valve and see the effective orifice area that we obtain with each size, this is the Myval THV series. This is the SAPIEN 3 series, and we can see that apart from the 20mm size valve, this was systematically a better effective orifice area for the Myval THV series. And if we have a look at the Evolut THV series, we can see that the hemodynamics, the effective orifice area, was comparable. Remember that only 26 and 29 valve were used, also 34, but this could not be compared because the extra large sizes were not included in the trial. And here is the whole picture. In 1 week, you will be able to read the full results in Lancet. I'm sure there are going to be a lot of downloads in the website of the Lancet to read this in detail and also to compare each one of the 3 devices that were studied. And the conclusions are that the landmark trial is the first head-to-head trial comparing the 2 balloon expandable valves and 1 expanding valve based on BARC criteria. The landmark trial has expanded the indications of TAVI to those with complex anatomy, such as small annuli and also bicuspid aortic valves. The landmark trial established the non-inferiority of the Myval THV series compared to contemporary THV series for early safety and effectiveness at 30-day follow-up, including all-cause mortality, all stroke, bleeding-3, acute kidney injury, moderate or severe paravalvular leak, and new permanent pacemaker or major vascular complication. When the effective orifice area of the conventional THV sizes 2023, 26, and 29 were compared to the Myval series, there was a significant larger effective orifice area in any size above 20 millimeter valves, comparing the two balloon expandable devices, and similar comparing Myval to Evolut series. We believe that the availability of intermediate sizes enables a precise and appropriate matching of devices to the anatomy of the patient, and therefore this is why probably the investigators chose these intermediate sizes in 48% of the patients. And we don't know the impact in the durability. These better hemodynamics might have an impact, but we will have to see this in the 10-year follow-up that we will perform. Thank you very much.
Thank you very much, Ignacio. Must say this was an extremely well-conducted study and must compliment the investigators for these positive results of the landmark trial. Must compliment the fact that the study gives us greater confidence on this novel transcatheter heart valve. And the day started off by the landmark presentation in the late-breaking trials in the morning by Dr. Patrick Sorois, and of course we have the principal investigator here. So before we go around the table, I think it's just valid to have comments both from Patrick as well as Andreas on the landmark study, which is certainly going to affect and influence transcatheter heart valve usage of Myval across the world.
Yeah, I think it's a step forward. I think that the fact that the technique of the intermediate use of size has been embraced so quickly by the community. I mean, immediately the number jumped to 42, 51. In the trial, 48%. When you do something in a trial, it's not necessarily directly embraced, and here it was the case. So I think that's a step forward. I think that we emphasized this morning that, and Davide said that, we stimulate the competition. You know, basically when you see the Resilia now and the JAK intervention, and you see these pictures en face, and you see that the suture, the thickness of the suture from the previous generation to the Resilia has been reduced substantially. And that's what the domestic technology of India has done 3 years ago. So they had some edge, and we see some difference. We don't know if the differences will make the difference in the term, long term, and the prognosis and durability of the valve. But I think that, you know, it's still recent. I think there's somebody in the seventh heaven who is probably happy about this improvement. Yeah, and that's Alain Cribier.
Andreas?
Well, short answer. I mean, this is a valve that isn't there as of today. It was there a year ago, 2 years ago, and it's in widespread practice in India and in some countries. But today it has truly arrived with a properly done randomized trial with data that are out there to be read, and I think that justifies its existence on our shelves.
Very good.
Comments from, final comments?
Well, I
yes,
think
we can have a round of comments from the.
Yeah, so I would like to congratulate Professor Baumbach, Professor Serruis, also Ignacio, Amat Santos, and the entire study team of this trial, of this landmark trial, because landmark is putting the world on notice. There's a new kid in town, and that is Myval.
Any last words, Nico?
No, again, I'm just you know, blown away by the technology in terms of sizing. That's what really gets my attention with this valve, and the way it's deployed, it's pretty, rock stable and beautiful results. And again, the clinical evidence demonstrates that. So I think we're in good shape.
Maybe a flash question from editor to editor. What is the most urgent post-hoc analysis or pre-specified endpoints you want to share next?
Yeah, there is a larger plan. I mean, if you have attend or not attend the dedicated deep dive on the trial, there was a lot of information. Your frustration of this morning would have been cured because we talk intensively about the multi-slice CT scan and the relationship with the categorical nominal size and the effect of the effectors of this area. Now, to respond to your question, I think we will first go very quickly for an assessment of the different level by win ratio. We have done the Delphi. We will do a Delphi also with the patient, which is more critical. And that will become, because everybody these days present the data with the win ratio, what I think which is important. Certainly in London Valve, we will present in more detail the 3 groups, which are powered. I mean, that's quite amazing that people don't realize that it's power for the contemporary and the Myval, but it's also contemporary power for the different group. So I think that we will learn a lot about these things, and then progressively we will have the long-term follow-up of the short-term follow-up 1 year, which might be a PCR next year, because the last patient was enrolled in December. So we work quite quickly and intensively to have this Lancet and everything analyzed and adjudicate. One thing that I want to repeat is this VARC3 is not a sinecure. I mean, there is 18 tables in the document, and there is 94 parameters. It's the first time in my career that I have more adjudication than patient, okay? So that was Marty Leon and many people have done. I think it's very good, because in medicine, when you have a large burden, 26%, you have to work on it. You know, in coronary stenting, what do we do with 5%, 6%? The game is over. But here, there's still 26% of things that has to be improved. And that's good for trials in general. So I'm for VARC3, even if it is a lot of work. Yeah.
Corrado, one of the most impressive aspects for me from this trial, even though I've been using Myval for literally since its inception and since the first in-human study, which I was the principal investigator of, was the fact that I didn't realize the effective orifice areas were as large as the supraannular valves we used to. That was really impressive. That caught my attention straight away and was very, were you impressed with that? I mean, that was one aspect that I want you to comment on. Yeah.
I would say that this is a valve that has a behavior like a supravalvular, because the suture is made in order to keep and maintain the leaflet vertical. And this is the reason for having such large area.
Yeah, and let's hope it influences its long-term durability and, of course, longer-term
shortening 19%.
Yeah, shortening 19%.
Just one last comment. I have to say that I honestly believe that the presence, at least in my lab, of 5 different prostheses and platforms is honestly the way to improve all of them. I need to congratulate the company, because now there is, as Nicola said before, is a new kid on the block. Not that new, but definitely it will be the occasion for all the other companies to keep improving and studying and doing research and development. This is what we need.
So I think at the end it falls upon me to congratulate Myval as well. Yep. I think it's Myval Life Sciences has put India's science, technology, research on the world map. And it's going to actually be of much benefit to a much larger population of patients across borders. So congratulations, Myval. We end the day with you. Well done. Great job done.